Yes, Dr. Dhanit, you can switch on the video. Yes.
Okay.
So, good morning, friends. Welcome back to Saturday Club of Baroda meeting. Today we have with us Dr. Dhanit Khetwani. He is a consultant ophthalmologist and oculoplastic surgeon practicing in Vadodara. He did his MS ophthalmology at KIMS DU and then Karad, and then he did fellowship in oculoplasty at Arvind Hospital, very reputed eye hospital in Madurai. He has a vast experience of over 7 years with more than 3,000 surgeries to his credit. His main area of interest are eyelid surgery, orbit, ocular tumors, etc. He is affiliated to Vadodara Eye Hospital, a very reputed hospital in Vadodara of many years. And he is also affiliated to other hospitals in Vadodara, also at Seva Rural Jagadia and Sumandip Vidyapit. And of course, he has his own private practice in Vadodara. So with this brief introduction, I request Dr. Dhanit to start his talk on recent advances in dry eye management. With more and more digitalization, we see a lot of patients, even pediatric patients with no dry eyes. So it will be very interesting to listen to Dr. Dhanit about how do we manage these dry eyes. So thank you, Dhanit, for welcome to Saturday Club of Baroda. And
Thank you.
Talk now. We have about 40-45 minutes for you to talk and
Okay,
keep
sir.
about 10 minutes for interaction. So over to you. Thank you.
All right. Just a second. I'll just start my screen sharing.
Yeah.
So I hope my screen is visible to all.
Yes, yes.
So good morning, one and all. Thank you for joining and giving me an opportunity on this wonderful Saturday Club morning platform. It's glad to see that all are so energetic on this Saturday morning. And I think this getting up in the morning is restricted to a certain age group, and the youngsters are not very used to getting up early in the morning. I also had to make a lot of efforts to get up early. But yeah, whenever we have surgeries, it's the best time to get up in the morning and do them. So I'm an eye surgeon, and I'm practicing in Baroda since like last 7 years already. Sir has introduced me, so I won't go into it. But I would like to say that my PG thesis was on this topic, and it's very near and dear to me. I had seen almost 200 specialty cases in dry eye clinic at my postgraduate institute. And I was surprised to see so many variations and so many findings which maybe are yet to be discovered and are yet to be published in research. And the tools which are there since a long time. They're very useful, but I feel that the newer tools which are there in the market and are yet to be introduced commercially are very effective. So speaking about uh, dry eye, just a second. So it is a multifactorial disorder. It's not just a condition of the eye. It is relevant to all the practitioners who are practicing today. And I'm very sure that in the clinical practice of all physicians and practitioners, someday, a patient comes with a complaint that I don't feel comfortable, I don't feel fresh, my eyes are heavy, and I don't see very clearly. So not always in previous times, we used to think that not seeing clearly means cataract, but now it's not like that. Young patients come to the clinic, they say that I cannot see clearly, I cannot focus well. Within a span of 30 minutes, the vision gets blurred. So today we are focusing on this aspect where dryness not only creates symptoms of ocular irritation and all, but it creates a symptom of blurred vision, photosensitivity, and all other things. Today, learning objectives will focus on the definition, as the definitions are always important in the medical field. Epidemiology, pathological mechanisms, pathophysiological mechanisms which play a role in the clinical practice, and also the dry eye causations, which are the modern diagnostic modalities and the classifications, which has been throughout many years, outlining the clinical standard treatments and the emerging therapies which are coming up. Moving on to the definition. So the most accepted definition which we used to mug up during our PG times, at that time it was just mugging up, but now as we see, it takes into account everything which is there, starting from the pathophysiology, the symptoms, and everything. So basically, it is defined by Tear Film and Ocular Surface Society, Deuce 2 workshop, which was the study which was held. So they define it as dry eye disease. It is a multifactorial disease of ocular surface characterized by loss of homeostasis of the tear film accompanied by the ocular symptoms, in which tear film stability, hyperosmolarity, ocular surface inflammation, and neurosensory abnormalities play etiological roles. So it is prudent to know that the etiopathology which plays a role, not only it is anatomically relevant, but also pathologically relevant. Previously, we used to have older terms like keratoconjunctivitis sicca or dysfunctional tear syndrome, but now uh, dry eye disease is the term which is used for all these symptoms. So classifying the dry eye, basically depending on what is the mechanism of dryness, it might be a low tear secretion or maybe an increased evaporation. So low tear secretion is termed as aqueous deficient dry eye, where the lacrimal gland fails to produce enough of the aqueous layer of the tear film. Now, the aqueous layer is the main layer which helps to form a clear film. The tear film is clear because of the aqueous layer. It contains water and electrolytes. And this can generally happen, the aqueous deficient thing can generally happen in Sjogren's syndrome, where lymphocytic infiltration is there in the lacrimal ductules, and due to which the tear secretion is low. That can also lead to the inflammation of the ductules. And other causes, like in the case of non-Sjogren's causes such as age-related atrophy, chronic contact lens use, or post-radiation. So wherever there is a reduced tear volume, we classify it under the aqueous deficient dry. In contrast to this, the evaporative dry, where the tears are produced normally, but they evaporate too quickly. Now, this is very straightforward thing nowadays, where a workplace digital screen usage has increased, the evaporation has increased, and the diet and the lifestyle modifications which have happened through many years. So these are the factors which are mostly important in this kind of a classification. So intrinsic factors such as meibomian gland dysfunction, which produces meibomian oil deficiency, lid aperture disorders, where eyelid malpositions or inadequate eyelid closure may be one of the main reasons. Low blink rate. Low blink rate, we all must be having. Now, as we are focusing on the screen, we should all know that blink rate should be around 15 to 16 per minute. And reduced blink rate causes evaporative dry eye. Now, the extrinsic factors like vitamin A deficiency, topical drugs, oral drugs, or contact lens wear or ocular surface disease such as allergy. So all these are a classification, not a very broad classification, but definitely the treatment varies according to this classification. Now, the causes of dry eye already mentioned by me, that the workplace where the blink rate has been reduces by around 60% leads to increased evaporation. So when It's the studies show, and also practically when you can test when you're seeing mobiles or the screens, the blink rate is not more than 4 to 5 times a minute. So imagine that the eye is continuously open. Whatsoever tear film composition is there, the evaporation will occur. Extended reading, driving, or close of work. So all these things, eye remains open for a longer time. There is no blink, and the evaporation occurs. So other eye conditions such as meibomian gland dysfunction gives rise to around 60% of cases of dry eye. So meibomian glands basically are straight parallel glands located in upper and lower eyelids. So what they do is they secrete the lipid layer and they form a major component of the tear film. So once this lipid layer becomes deficient, it leads to faster evaporation, more common in contact lens wearers, and also other conditions such as eye surgeries like LASIK or cataract surgery. Previously, cataract surgery, as you might all be knowing, that we used to put a bigger incision on the sclera, and this led to transient damage or disruption of the corneal and conjunctival nerves, producing postoperative dryness. Blepharitis is a modern day issue, more prominent nowadays. Inflammation of the eyelid margins happens. There is a crusting of eyelids. Eyelid hygiene is not that great. That is one of the reasons of blockage of the meibomian glands. Other conditions which affect, which are secondary to the systemic health, oral medications such as antihistaminics and psychiatric or neurotropic medications play a role in directly causation of the dry eye. Coming on to the environmental factors, low humidity, air pollution, high winds, very particular setup for a Baroda climate. So that is one of the reasons where the dry eye allergies and all are common. And not to forget the age-related conditions like postmenopausal factors in females, where there is down regulation of the hormones, which lead to the direct causation of the dry eye. Also, the old age can lead to atrophy of the lacrimal glands. So these are all factors. Many factors are there, but some to list here. So that's why it is known as it is a multifactorial and interconnected eye condition, and in general, general condition of the body. So moving on to this inflammatory cascade, as we already said that tear film is important. I'll be talking about tear film in my further slides. It's prudent to know that the tear film, which is there, if it becomes unstable, it leads to hyperosmolarity. Now, hyperosmolarity, why? Because once the aqueous layer or the water layer evaporates, the osmolarity increases. As the osmolarity increases, it directly affects the epithelial cells, the goblet cells, which are present in the conjunctiva, and they lead to the secretion of the inflammatory markers, which are the inflammatory biomarkers, and which leads to the goblet cell and the mucin cell epithelial damage. So now this damage again leads to the punctate epithelial erosions. The surface is not that plain as it is required for the tear film stability. So again, it leads to the tear film breakage and hyperosmolarity. So this is how it completes the cycle. And another aspect to it is in this diagram, if you can see, the tear film instability also changes the conjunctival and corneal flora, which is there, which indeed releases bacterial toxins, which causes eyelid inflammations, lipid changes. So the flora changes are an important thing. Not that only blepharitis can cause dry eye, chronic dry eye can also cause inflammation and eyelid infections. So this is how a cascade plays, and it's important that it is the major important factor for the pathophysiology. But depending on this, also we tailor the treatments for the patients. Now, coming on to this tear film, a tear film basically creates a layer over the cornea. Now, this is a cornea. It lubricates, not only lubricates the eye, but it has a major role in the refraction of the eye and focusing all the rays, parallel rays, which are coming towards the retina. Now you can see we have marked an outermost layer, which is the lipid layer. So lipid layer basically, which is secreted by the Meibomian glands. Its function is to prevent the evaporation, maintain a smooth optical surface. Second is the aqueous layer, which already said is produced by the lacrimal gland and ductules. Contains water, electrolytes, proteins, and antimicrobial factors like lysosomes. Innermost layer is again a mucin layer or a mucus layer, which is zero point 0.5 microns thick, and it creates a surface tension, and the stability of the tear film is due to the inner stability is due to the mucin layer. Now, understand one thing, that the lysosomes and all antimicrobial factors are there in aqueous layer. As it evaporates and the dry spot is created directly, all this apoptosis occurs on the corneal and conjunctival surface. Now, already, as I mentioned, Meibomian glands produce the lipid layer, which is the topmost layer. Lacrimal glands, the aqueous layer, and the goblet cells produce the mucin layer. Now, focusing on different specialities where certain conditions which may directly lead to the dry eye. So, from a rheumatology standpoint, we have cross referrals from rheumatologists, and also we send many patients to the rheumatology clinic after the dry eye disease have increased. So, rheumatoid arthritis and lupus are classic systemic causes. Lymphocytic infiltration causes the lacrimal gland uh, tissue to be blocked, leading to the aqueous deficient dry eye. And next is the endocrinology. We already know that diabetes is one of the major aspects and major condition where a direct relation to the dry eye is that Meibomian gland dysfunction is more increased and upregulated in cases of diabetes mellitus. Thyroid eye disorders, why? Because there is a decreased eyelid blink rate, also deposition of glycosaminoglycans in the muscles of the eyelids. So that causes a direct dry. Even in some cases of hyperthyroidism, there is and increased proptosis, which directly correlates to the dry eye. Dermatology like rosacea and seborrheic dermatitis directly leads to meibomian gland inflammation. Psychiatry drugs, in neurology drugs, some of them uh, they are related directly to the dryness. Postmenopausal and hormonal changes, where estrogen and androgen imbalance can affect the tear production. Antihistaminic beta blockers in pulmonary internal medicine or the general practice. Lid malpositions, lag of thalamus, facial palsy can all lead to dry eye. So it's not just that eye people can get patients of dry eyes. Everyone can get direct or indirectly the patients of dry eye, and the complaints can be very relevant. Now, this figure basically shows how eyelid tear film is created and why blink is important. So I'll just show you that this is a lateral aspect, and here the lacrimal gland is there. It produces the tears like a wiper of the car. Once a blink is there, so they spread throughout the eye. They lubricate, they clean the eye, and there's a small punctum in the upper and lower eyelid which drains all these tears inside the lacrimal duct into the nasal cavity and the oral cavity. So once the blink is formed, with the blink, tear film is formed with the help of the lipid aqueous and the mucin layer. And important, the blinking is so important for the causation of the tear film stability. So what happens when there is a quick evaporation and the tear film doesn't stay very healthy? So there's a dry spot, as you can see here. This is a normal tear film, which should be that this one, and this is a tear drop. So basically, you can see the tear film is not very stable. There's a dry spot. Again, the kind of rays which are split here are different, and these are different. So basically, this causes a blurred vision, acquired astigmatism or the cylindrical power, and photosensitivity. So this is for the refraction, which is the eyelid, the rays which are falling are not parallel to the retina, causing blurred vision. But not only that, the other symptoms which are there can be also irritating for the patient. Patient generally comes into the clinic with uh, complaint of heaviness, burning, uh, foreign body sensation, irritation, sometimes redness, stinging sensation, and blurry vision, of course. And the most common complaint nowadays is that because of the LED lights and indoor work, that the light sensitivity has increased. They are working on computers. As soon as they lift up their face, they can see that the rays are not very parallel and photosensitivity is there. So all these are common symptoms which are relevant for now, depending on what are the severity and how much discomfort and the visual symptoms are there. It is graded into four grades: mild, mild to moderate, severe, and very severe, depending on the symptoms. So this is the symptomatologically grading, but we need to grade properly if you have to manage well. So I have created a practical sequence of dry eye diagnosis. So patient history is always main. So we have certain questionnaires like OSDI questionnaire or SPEEP questionnaire, very easily available on Google Images. So you can just download one and see what are the aspects of all these questionnaires. So I think it's around 30 to 35 questions which are there, and relevance is always there, or the dry eye is diagnosed with that questionnaire if the score is more than 16 to 18. So all these questionnaires are important because they just don't only focus on the symptoms, but also focus on what kind of background is there, what kind of work patient is doing. Then coming on to the clinical tests which we do, there's a tear film breakup time, which I'll be showing in the next slide. Ocular surface staining, which is relevant to see the ocular surface damage. Schirmer's test, which is very common, which all might be knowing till now, and examination of the eyelid margins. So once a patient comes to the clinic with these complaints, stain is something which we do. So stains are kind of a friend of an ophthalmologist. We have different stains like lissamine green stains, fluorescent stain, and rose Bengal stain. So all have different roles. Like when we speak about the fluorescent stain, you can see in the tear film breakup time, that is the first test. So what it generally shows is that when the eyelid is opening, the green layer which is forming, we see under the blue light filter. That's why it seems green, but the fluorescent dye, as you know, it is orangish in color. So once the evaporation occurs, we can see a dry spot. Immediately as the dry spot occurs, we have to see the time. To calculate the time, normally it takes around more than 10 seconds for the tear film to evaporate in normal conditions, but if there is a dry eye, it may evaporate in lesser number of seconds, and depending on that, we can grade it. So again, this is one of the diagnosis of evaporative dry eye, but not very specific for it. The next one is a Schirmer's test. Again, Schirmer's test is one thing that you can see the strips which are placed inside the cul-de-sac or the conjunctiva, the eyelid sac which is formed inside, and we see how much the tears which are there are spreading on the strip. So it is kind of a pH paper. It doesn't show definitely the pH, but it shows how much is the tear, the range of tears which is produced. So normally, if the reading is around 15 to 25, it is graded as normal. And if it has less than 10, definitely there is inadequate tear production, and this can lead to a diagnosis of aqueous deficient dry. Again, not very specific, but point to note here is that when we put anything inside there, it creates irritation. It can cause a reflex tearing, which is not a very healthy tear. So we might put an anesthetic agent and do the test to see whether proper interpretation is happening or not. That is known as Shermer's 2 test. Again, there's a lissamine green staining where we grade the stains according to the three areas: cornea, lateral, and medial conjunctival aspects. And we can see here that if there is uh, the number of the dots which are seen both in fluorescent and Lissamine green. So fluorescent is used for cornea and Lissamine green for the conjunctiva. Again, the rose Bengal staining is important where there are epithelial erosions or ulcers. So rose Bengal is something which stays inside, and we can see the erosions or the corneal, the ocular surface damage. So these are the basic tests which are there. The very hi-fi tests which we usually don't do in our country and are very a little bit costlier from our aspect are tear osmolarity test by Tear Lab system. Very common in US nowadays as they have a very good system of the claims and all, so they can easily spend money in all these things. So what it does, it is a very easy thing that it collects tears just like glucometer. It just collects the tear and measures the tear osmolarity. Important note here that normal tear osmolarity is around 308. A difference of more than 8 is a diagnosis of hyperosmolarity. One of the other tests which is done is the Inflamma Dry device, which is also a new test. Again, collects the tears, and it's like a kind of a pregnancy strip. So it gives a result like positive or negative, uh, just like the strips which are available in the market. So this shows whether the matrix metalloproteinase are upregulated or not. So this is just for the inflammatory markers. Clinical testing also includes the Meibomian gland testing. So we have many other hi-fi devices, but as you all know, to test the power, we have an autorefractometer. So autorefractometer generally shows this kind of an image, and we can easily see this makeup of the Meibomian glands. You can see this is a normal structure where you can see the parallel arrangement of the glands, and all the glands are open. And also this is a lid margin where you can see the openings which are fine, which are not blocked, and where there is no any white secretion which is there. Again, the BNC, you can see the B image where blockage and the number of glands have reduced. There's certain kind of eyelid deformity and thickening. The Meibomian gland orifices are not that clearly seen but are blocked. And C, again, the Meibomian gland orifices are very faintly seen. Arrangement is not parallel. So these both conditions basically which are shown are diagnosis of a unhealthy Meibomian gland and Meibomian gland dysfunction. It can be easily seen in an autorefractometer, which is there. We don't need any hi-fi equipments to diagnose Meibomian gland dysfunction. So diagnosing Sjogren's syndrome, which is one of the important systemic conditions which we most often correlate during the diagnosis of dry. So subjective description of the oral symptoms is important here. They have given a checkpoint of around 6 criteria, and out of which the 4, if they're fulfilled, like oral symptoms, subjective oral symptoms, subjective ocular symptoms, objective signs of oral dryness or objective signs of ocular dryness, serum autoantibodies, which are nowadays easily available in Topranis and all other laboratories. So anti-SSB and anti-SSA antigens are commonly which we test. And then if no other diagnosis is made, we can also take some biopsy from minor salivary glands or the ocular tissue also. So correlating it with the Sjogren's syndrome is important to make a particular diagnosis. So now what are the tests relevant to the diagnosis? Already, as we have seen that autoimmune disorder like Sjogren's, we have to do this antibody tests, and rheumatoid uh, factor, and then the testing of the rheumatoid factor should be done. ANA profile, ANCA profile can be done. That can be a direct relation to the rheumatology. ESR CRP to see the upregulation of the inflammatory markers, the diabetic profile, thyroid profile, serum estrogen, testosterone, DHEA, to see the androgen deficiency or down regulation, most commonly in postmenopausal women or androgen deprived males. Vitamin A levels can be seen, but not very important always. Definitely, it is a good marker to see the epithelial integrity. And CBC with differentials should be done to see any anemic causes. So these are the basic tests which can be done. Now, moving on to the treatments and recent advances. Uh, so treatments, if we see this green bottle, which we always focus, if we remember dry eye, it was a general practice that just give this green bottle, everything will be fine. Not only the general physicians, but general eye doctors and ophthalmologists used to prescribe this green bottle always. But now the treatment has shifted because there are multifactorial, there are many factors which are responsible for the causation. Not one size fits all. So I'll just start with the non-pharmacological treatments which are available. So this is basically the hot fermentation, which is very cost effective and a good uh, treatment for all the patients who are having dry eye. So what we do here is we ask the patient to do a dry heat fermentation. We should not dip the cotton cloth inside the water, warm water, or anything. You just have to heat it, whether you can heat it with the iron or you can take a normal tawa or anything on. With the help of it, you can heat it and take the hot fermentation. The hot fermentation is important. It releases the clogged up meibomian glands which are there. Another one is the lid hygiene. There are eyelid wipes which are very easily and commercially available in the pharmaceutical stores. Instead of using some other cloth, we can use this eyelid wipes to clean the eye. Many females nowadays which come into the clinic with the help of their saris and the cloth of their cloth, they just clean the eye, or the tissue, the handkerchiefs, they are cleaning their eyes. So I always instruct them that eyelid wipes are important, and they come out of the packet, they're sterile, they can help you with the lid hygiene. Again, lid cleansers are there. Many lid cleansers are available commercially. Almost 30 minutes are over now inside the into the presentation. We all might be feeling some of the eye strain because we are seeing the digital screen. So prudent and very important, marked by WHO also, that 20-20-20 rule, that every 20 minutes spent on the screen, look away, blink for 20 times, look away in a way that look around 20 feet or more than 6 meters away, and at least for 20 seconds you blink. So when this blinking occurs, again the tear film is reformed, the tear film stability is reattained, and the dryness goes away. This is a LipiFlow, which is a modern non-pharmacological treatment. Not all doctors might be having. What it does is that it creates a mechanical pressure on the meibomian glands, as you can see here, and this mechanical secretion releases the clogged up glands. So this are the non-pharmacological treatments. Now we have seen a pathophysiology which plays an important role. So depending on the pathophysiology, so we can tailor the treatments which are there. For the routine mild dry eye patients, artificial tears will do the job. And when we diagnose the condition to be an uh, evaporative dry eye, we can use in combination to the lubricants, the thicker drops like PEG, PPG, or HPMC, sodium hyaluronate. All these kind of drops can be used in when there's a diagnosis of increased tear evaporation. Decreased tear production, we can definitely use lubricants. In addition to this, we can use a cyclosporin, weak steroids, and punctal plugs can also be used. I will be taking in detail all these things in further slides. Ocular surface inflammation directly can be reduced by topical weak steroids, immunomodulators, and omega-3 supplements. Hyperosmolarity can be taken care with a combination of L-carnitine and erythritol and the normal lubricants. Nowadays, many formulations are available also in the Indian market. So goblet cell loss can be taken care by the vitamin A ointments, which are commercially available easily, and the environmental factors with the help of protective eyewear and blinking exercises. So depending on pathophysiology, we can, if we tailor the treatment, it is always good for the patient. Now, as I already said, that there's not only one green bottle which is there, which contains 5% CMC drop, but there are different types of lubricants. Some are the aqueous base, as I already said, that the CMC eye drop, they increase the tear volume for mild dry are good. Again, viscoelastic lubricants which contain thicker materials increase the viscosity for moderate dry eye, post LASIK, and severe dry eye patients. Lipid containing emulsions, castor oil is good, not of very allopathic kind of a treatment, but again, newer components are there. Cysteine balance is one commercially available drop which is there in US, and NOV03 is one of the newer component which is studied extensively now. So these are helpful in evaporative dry eye with meibomian gland dysfunction. Gel formation ointments provide a longer retention time on the ocular surface, are good for the people who are not very good at treatments. They're not putting drops regularly, so eye ointments work well. Sometimes there can be a dryness, sometimes can be blurring can be there because of the thickness of the ointment, but that lasts not for more than 10 minutes. Focusing on topical corticosteroids, they block the phospholipase A2 inhibitory proteins, and they reduce the inflammatory markers, reduce the inflammation. This is a weak steroid, loteprednol, which we generally use for allergies also. And in combination with lubricants, if we use it, it is definitely better. It reduces the inflammatory markers, inflammatory cascade is broken, and the tear filaments, the stability is also maintained. Not, it's important to note here that we also have to check pressures, intraocular pressures when we are putting topical corticosteroids. Might directly do the upregulation of the production of the aqueous inside the eye, leading to the high IOP sometimes if we use it for the chronic duration. Cyclosporin A, newer treatment, definitely since the last decade has been a very common thing. The cycloimmune drops, the brand name as I have shown here, are commonly available in your nearby medical store. FDA approval was done in 2002 for 0.05%. We are using till 0.1% in our clinical practice now. What it does is that it inhibits the calcineurin phosphate pathway by complex formation of cyclophiling, and reduces the transcription of T cell activating cytokines and interleukin 2. So basically, again, there's a break in the inflammatory cascade, and definitely the vicious cycle is broken. Also, it releases the parasympathetic neurotransmitters. It is kind of a secretagogue and increases the tear production. Again, it is a multifaceted drop and a very good drop, little bit costlier, but patients are very happy for a long-term treatment with cyclosporin. Omega-3 fatty acids, nowadays all physicians might be prescribing for various conditions, but they're essential fatty acids for also for the ocular surface homeostasis, and work by blocking pro-inflammatory eicosanoids and reduce cytokines through the anti-inflammatory activity. Tetracycline ointments and also some drops were there in the market, but tetracycline ointment is very commonly available. It has a bacteriostatic and anti-inflammatory effect. They reduce the synthesis and activity of the matrix metalloproteinase and other inflammatory markers. Macrolide antibiotics such as azithromycin, very commonly available. You can get anywhere, every the pharmacy shop. So they inhibit the bacterial protein biosynthesis by preventing peptidyl transferase from adding the growth peptide into the chain. So basically, they also improve the meibomian gland function, reducing the bacterial colonization and the bacterial toxins which are formed. With not only with the anti-inflammatory effect, but the antibacterial and the bacteriostatic effect is one of the major roles played by the azithromycin eye drops. Also, there are formulations in the eye ointments based on eye ointments which can be used in 1% volume. Next, one of the important things which is punctal occlusion. Prudent to know that the lower punctum which is there responsible for 70% of the tear drainage into the lacrimal gland. So once we block this, the tear film height automatically increases. So in patients with autoimmune disorders or very chronic dry patients which are not very susceptible to treatments, the normal treatments such as lubricants, punctal occlusion is the one of the best and the latest treatments, both available in temporary and permanent solutions depending on what kind of material we are using. Very easy to put, just takes couple of minutes in the OPD setup or also in the OT setup, we can do it and stays in till the time patient are comfortable. Once the patient complains that, yeah, now I'm getting tearing and watering is more, we can remove it. It is totally reversible procedure. So punctal occlusion is one easy procedure. Might be a little costlier for some patients, but not cost more than 13 to 14,000 for the whole procedure. So recent treatment modalities which are coming up outside India and now might be introduced in our country also. So I'll play a small video. So this is a tear care system which is kind of providing hot fomentation directly on the upper eyelid and lower eyelid. We don't need to put any cloth. So we have this two lids which are connected to upper and lower eyelid, and it creates a mechanical effect also and also provides heat. So this is a tear care system which is now coming up, not very costly, but as a one-time investment for an ophthalmologist, if might be available very soon in our country also. Coming on to the newer treatment, which is under trial and also used at many setups, varenicline nasal spray, which was previously used for de-addiction in smokers, chain smokers. So they block the nicotine receptors, activate the parasympathetic ganglia, and block the antibodies to muscarinic receptors, anti-SSB antibodies, and rheumatoid factor inflammatory cytokines. So they directly block the inflammatory cascade and are also known to be a secretagogue by parasympathetic secretions. So this is one of the newer treatments where there is no need to put any eye drops inside the eye. Directly nasal spray might help to increase the tear production. Not commercially used well as of now, but definitely one of the upcoming treatments. So last but not the least, intense pulse light therapy. Many practitioners in Baroda have started this, and it's a good thing that patients are also happy that the meibomian gland and all, like whatever we tell them, are taken care in the clinic itself. So this basically provides a heat or a pulse light therapy to the meibomian glands. Also, kind of they balance the ocular surface in some ways. So this is one of the newer modalities for drainage of the meibomian glands which are clogged up. Contact lens delivery system was previously used in cases where advanced glaucoma or management of the glaucoma where there's a drug release depending on the IOP increase. So this system is now also used for dry and is also an upcoming modality where the dry eye or the tear film instability is tested by a chip or a sensor, and directly there is a drug release of certain drugs such as cyclosporine. So these are the upcoming modalities, but we have to understand that dry is something which is not only treated by eye surgeons, will require cross references to all the specialties more commonly with the rheumatologists. So thank you all. I think I am on time. I've been interactive with all.
Absolutely.
Yeah.
So you can stop the screen share.
Yes.
Thank you, Dr. Dwanit. It was an excellent, very informative talk on a very common subject.
Thank
So
you, sir.
the house is open for any questions, discussions. We have Dr. Pradeep Seth also with us. He's a very senior ophthalmologist and very much active part of this group. Pradeep bhai, if you have any comments.
Yeah, good morning to everybody. That was an excellent presentation, Dwanit.
Thank you, sir.
Dry
Well,
eye
sir.
is not something that one can so elaborately cover in such a short time, and
Yeah.
you did that excellently.
Thank you, sir. Thank you.
So wonderful. Um, so many modalities have been coming, and they are all going to probably face the test of time, and in terms of efficacy, in terms of cost efficacy as well as the definition of the etiology and the management pathway. You have really very well laid out the whole thing.
Yes.
But uh, can you elaborate on one thing? You mentioned that it's the dry heat that you want. So
Yes.
why is that?
So what, like in not only for the dry, as you might be knowing, for sty and hordeolum and all, what patients generally do is that they dip the cloth inside the warm water. Now, water is something which might contain many pathogens, also bacteria also, and generally they use tap waters. Not everyone is accessible to mineral water or the RO water, and
Mhm.
see, cleaning the eye with warm water is fine, but again, hot fermentation, if we do it with a dry heat, it is focused on that particular point, and it is much better than the uh, impure water which is available in the house.
Okay, so if that is the rationale,
eyeglass clean करें ना हम लोग को।
probably
Hmm.
um, the boiled water or the fermentation with the cloth or the cotton dipped into boiling water would take care of the microbial part of the story, and it's something which is so simple and available for everyone to use. So wondered if would just be agreeable to having a
We actually, sir,
boiling
we
water.
had
Yeah.
done a small study in Arvind
Uh,
where why dry heat and wet hot fermentation, what is the better thing? So
okay.
what we found out was that obviously results were different, very subjective from patient to patient, but we found out that the patient's experience was that even if we dip into the boiling water or warm water, the heat is not that much transferred. As you must be knowing, water condenses, and also the heat which should be a directly kind of applied to the meibomian glands does not reach the particular target. That's what we had seen at that time. But definitely,
Uh-huh.
many clinicians advise wet fermentation also. That is also one of the things which people do.
Yes, yes. So
Yeah,
only that short point, it's so easily available to
correct.
everybody, makes the treatment, if they understand that it's really the sterile water that's required and as much
True.
heat as is possible should be transmitted on the local part. So just this one comment. Please go ahead, Satish and
Yeah.
Dwanit.
Thank you, sir.
Thank you so
Thank you.
much.
Thank you,
Thank
sir.
you, Dr. Pradeep. Yes, Jagdish bhai, you have some question or comment.
No, nothing except saying that it was excellent information.
Thank you, sir. Thank you. It's my, it's gratitude to all of you that you spend your time in early morning and giving me a chance to speak here. And thank you all for this thing.
What about increased incidence of late with in kids also? I mean, we are seeing a lot of kids with computer vision syndrome where one of the reasons is dry eye. They get a lot of blurring and itching in the eyes.
To blame some person for that is the parent. So parents should be strict about it. Or not only dry eyes, if we see that the common, like the increased usage of the screens and the mobiles, they not only gives rise to dry, also there are conditions like esotropia or squint, which are more common, and the development of the refractive errors which are there nowadays. So any kid walks into the clinic, if you check their power, out of 10, 6 to 7 kids will be having some sort of the power. So that is one of the conditions which we are facing nowadays in our practice. Common mobile use, common digital use in children. They are definitely having dryness, but there are many other conditions which can happen.
So any other questions or comments? Okay. So if there are no questions, and we close this session. Thank you very much, Dr. Dwanit.
Thank
And
you,
we
sir.
look forward to your talk in future also on some other.
Sure. We'll be available for that. Thank you, sir. Thank you for the
Thank
opportunity.
you all for joining. We meet next Saturday morning again. Thank you. Thank you.
Thank you.